Hello and welcome to this podcast on hepatobiliary disease. My name is Mohammed Jabir. I'm finally a medical student. I've done this, and in this podcast, what I thought I'll be doing is be covering miscellaneous conditions on hepatobiliary disease, which commonly come up in EMQs and MEQs, as well as doing a final slide on tumors. Start off with autoimmune hepatitis. This is a liver disease associated with other autoimmune disease such as pernicious anemia. It commonly affects young and middle-aged women. The etiology of autoimmune hepatitis is in the presence of IgG and is an immunological abnormality. Patients complain of fatigue and malaise and would also possibly have anorexia, nausea, and clinical features. The patient would be suffering from signs of chronic liver disease such as edema, splenomegaly, megaly, and jaundice. Investigations done in autoimmune hepatitis, since it's an autoimmune disease, we're primarily looking at antibodies such as anti-nuclear antibodies, also known as ANA, and since there was a rise in IgG levels, we're taking a look at that as well. There would also be increased serum bilirubin and aminotransferase enzymes as well. And there might also be a requirement for a liver biopsy to confirm the case of autoimmune hepatitis. Treatment involves steroids, primarily prednisolone. Going on to the next disease, that's primary biliary cirrhosis. This is a disorder, destruction of the bile ducts, causing cholestasis, that is, obstruction of the flow of bile, eventually leading to cirrhosis. This disease commonly affects women in the age of 50. The etiology of PBC, it is an immune-mediated disease that damages the bile ducts, and anti-mitochondrial antibodies or AMA be present in most cases. Clinical features of PBC is pruritus, jaundice, which is the commonest complaint, and patients with advanced disease may also have steatorrhea and malabsorption. Investigations, biochemistry would show serum alkaline phosphatase and serum anti-mitochondrial antibodies would also be positive. Management of PBC involves using the drug called ursodeoxycholic acid, which is a bile acid drug which has shown a reduced immune response in PBC. Going on to the next condition of Wilson's disease. This is an inherited disorder, failure of biliary excretion of copper, resulting in the accumulation of copper and deposition in organs such as the liver, basal ganglia, brain, and cornea. Clinical features in Wilson disease: hepatic failure due to cirrhosis, neurological problems such as tremor, speech disorders, involuntary movements, and dementia. There might also be the characteristic Kaiser-Fleischer ring present in the cornea. Investigations would involve looking at copper levels, and copper levels, that is the total serum copper levels, be reduced, and ceruloplasmin, which is copper carrying protein present in the blood, would also be urinary copper, if collected over a period of 24 hours, would show an increased level. Management of Wilson's disease involves lifelong treatment, penicillamine, which is an effective chelating agent, that is, it removes copper from the blood. Going on to the next disease, that is hereditary hemochromatosis. This condition is characterized by excess iron deposition in organ. What occurs here is iron tends to inappropriately absorbed in the small intestine, leading to clinical manifestations due to iron deposition in the liver, the pancreas, the joints, the heart, and possibly the pituitary gland. Investigations would involve having taken bloods from the patients, which would show serum iron level or ferritin levels on biochemistry, and there would also be increased the total iron binding capacity would also be reduced. Transfer in saturation, which transports the iron in the blood, would also be saturated, that is more than 60%. Management involves venesection. Going on to the next condition of Budd-Chiari syndrome. This is a disease caused due to occlusion of the hepatic vein, hence obstructing venous outflow from the liver, for instance such as in thrombosis, resulting venous stasis plus congestion with the liver leads to hypoxic damage and necrosis of the hepatocytes. Etiology of Budd-Chiari syndromes involves a myeloproliferative disorder such as polycythemia vera and the accompanying hypercoagulable state, the commonest cause of Budd-Chiari. Clinical features in Budd-Chiari are right of pain, hepatomegaly, jaundice, and ascites. Acute disease may also present fulminant hepatic failure. Investigations involves ultrasound, since it is a disease affecting the blood vessels. Abnormal flow will be seen in the major veins or even the inferior cava. Treatment involves restoring hepatic venous drainage and as well as the treatment of complications related to ascites and hypertension. Going on to primary sclerosing cholangitis. This condition is a chronic cholestatic liver disease characterized by fibrosis of the intra and extrahepatic ducts. Episodes of ascending cholangitis and jaundice could occur. Aggressive disease eventually leads to liver cirrhosis. Cholangiocarcinoma, that is bile duct cancer, could possibly occur in up to 20% cases, and most patients are positive for ANCA antibodies. Liver biopsy possibly would show fibrosis around the bile ducts. Going on to the final condition, we'll be talking about liver tumors, hepatocellular carcinoma. Hepatocellular carcinoma developed on a background of cirrhosis, particularly viral hepatitis. Other factors would be aflatoxin, which is a metabolite of fungus. Clinical features would include weight loss, anorexia, fever, ascites, and pain. The rapid development of above-mentioned symptoms in patients with cirrhosis is suggestive of hepatocellular carcinoma. Investigations involves looking at serum alpha-fetoprotein, which would be elevated. Ultrasound or CT scan would show the large filling defects of the tumor. An MRI or angiography could be done when in doubt, as well as a liver biopsy to confirm the presence of the tumor. Management in hepatocellular carcinoma usually involves surgical interventions by way of a surgical resection, or if the patient is suitable for a transplant. That's about it in this podcast. We've looked at miscellaneous conditions which affect the hepatobiliary organs, and finally we looked at liver tumor as well. Thank you and goodbye.